Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by integrative medicine experts at the University of Kansas Health System. Give patients time, attention, and a personalised wellness plan. They offer consultations, nutrition, counselling, infusions, neuroanatomical acupuncture, and neurofeedback, all to address the causes of medical conditions, healing the whole person, body, mind, and spirit. Learn more at kansashealthsystem.com/integrative. Today I'd like to welcome back Dr. John Kim, who's been our guest twice before. Thank you for joining us, John.
Thank you so much, Linda. It's my pleasure and honor to join you and your listeners.
Well, you have moved and you're now in Kansas at the University of Health Systems. Would you like to explain your new post?
Yes, University of Kansas Health Systems is probably the biggest healthcare system in Kansas. And the KU Integrated Medicine, or University of Kansas Integrated Medicine, is one of the most oldest functioning integrated medicine clinics that encompass research, education, and clinical work. And in particular, we are one of the three academic centers in the U.S. offering IV nutrition, including IV vitamin C for treating cancer and other infectious issues or strengthening the immune system. And the second is Myers cocktail, and third, magnesium, and fourth would be glutathione. So we're one of the three academic centers that can do that kind of work. And of course, we are also big advocates of the use or atypical use of naltrexone, both known as low-dose naltrexone, which your listeners are very well educated. But there's also atypical use called microdose or ultra low dose naltrexone, which I am working on for the slide for Glasgow talk, which everyone of the listeners should try to come or subscribe to the video conference.
Well, exactly, because this show is going out in September, so the conference will have been and gone, but people will be able to still watch online. Yeah. Yes, so that is great. Yeah. Well, it's really good to know that you are back into the fold, as it were, in prescribing LDN. And as you know, John, you have a very big following. People absolutely love you. And you must know by all the Facebook posts that you must get such a doctor with an open mind, that's all I can say. And of course, you wrote an LDN book. Would you like to tell us about that?
Yeah, I'm sort of embarrassed about that book because it's still progressing work, number one. And I actually tell patients to buy your book. I think your book is very well written, and it's written by multiple people. And my book really is more evidence-based approach to looking at LDN. And it was really an attempt for me to write a review paper. And what had happened is that 2 years ago, just 2 years ago, journals, academic journals would say, we're not interested in LDN, go away. But now in this year, I've been invited by two journals to write review papers on LDN. So as soon as I record the second talk, which is going to be on microdosing of LDN, I will be writing that article, which is about how to use LDN for pain. And we will be talking about both of those topics here. But the book really focuses on review, and I think people really hated it because they said, I can find out more about LDN in internet. And I just was thinking to myself that this book really belongs in academic setting where we're talking about evidence, not what's possible, but what has been shown. And of course, in the discussion, we can talk about what is possible. And we'll talk about what is possible. I like to talk about atypical uses of LDN and also microdose of LDN, which is also atypical doses of use of LDN.
I've interviewed several doctors who use ultra low dose naltrexone for pain. And some of them still use it alongside of opiates. What is your thought on that?
Absolutely. I think that, there's a medication called Embeda, and Embeda is an opioid medication with LDN embedded in the core of it. So basically what it does is that if you crush the pill, the LDN in the core becomes available and people can go through a withdrawal reaction. And that's exactly how it's designed to be. If you swallow it as whole, nothing happens. You get the narcotic, the other end comes out. But if you crush it, then LDN goes to action. Now, this is important because it's not a therapeutic use of LDN per se, but we do know now that based on that experience, that LDN dose, the 1.5 milligram dose, is capable of creating a withdrawal reaction. So the old adage of don't use LDN if you're a narcotic or opioid medication, absolutely correct. That it's been proven. That's the function of that Embeda medication. However, there have been lots of studies coming out, and there was a failed attempt by a pharmaceutical company to market Oxytrex, which is an oxycodone and a 1 microgram of naltrexone, or the industry calls it ULDL, but it just sounds so weird, so I just say microdose naltrexone. So the microdosing of naltrexone is very interesting because it potentiates, meaning it makes the narcotic medications work harder, yet it is capable of blocking some of the side effects. So it's almost like magic. And they have several clinical trials to show it. Unfortunately, there were some problems with technical qualities to that trial, and ultimately they returned the patent or the medication rights to the Albert Einstein College of Medicine. But that kind of shows you that there are big players looking at naltrexone being used in low doses and microdoses, and some of them say even nanogram or picogram. And microgram means 10 to the minus 6, and nano is 10 to the minus 9. Pico is 10 to the minus 12. And I've first seen this not for opioid using patients, but I've seen patients who absolutely could not tolerate even 100 micrograms or 0.1 milligram, because the adage in LDN world is start with 1.5. That's the lowest dose. And I'm finding that's not true. Patients who have very low endorphin reserve, and I think that should be a talk for next year, and I will put that in for next year's topic to be covered more in detail. But basically, you have to treat patients as individuals. You have to get an idea of how much endorphin they have inside them. And if the reserve is low, then you have to use lower doses, maybe even microgram doses, maybe even nanogram or picogram doses, because I had patients who couldn't tolerate even milligram or microgram dosing because it just, they had, I think, no endorphins left at all. Mm-hmm. So now, if you use it with opioid medication, I've seen some initial impressive results, not by itself, because we know that it did not pass the test of science. So I've been utilizing LDN with acupuncture or microdose naltrexone, opioid medication, and acupuncture. And acupuncture is really cool because acupuncture and LDN, naltrexone, has a very close relationship. When they studied how acupuncture works, they know that naltrexone can block acupuncture pathway, part of it. So now I use it backwards. I use microdose naltrexone, and I let them continue the opioid, and then I use acupuncture to strengthen the endorphin system, and at the same time reset their brain so that they can we can challenge, meaning we can lower the doses of opioid. And this is a huge implication because in the world we have opioid epidemic and people are dying every day. People are dying, and you can use micronaltrexone and marry it with a second technique called neuroanatomical neuroendocrine acupuncture, and we can get amazing results. And I have, in Georgia, before I left my practice at Georgia Integrative Medicine, I remember one patient who thought that it would be impossible for him to reduce the dose of the opioid medicine with microdose naltrexone and also with neuroanatomical acupuncture. He had to go back to his pain doctor and saying that, hey, I don't need as much. Can you give me less? And they did.
What about the cannabis oil with LDN? Is that something you use or not?
So cannabis and oil and LDN is another fascinating topic because LDN and cannabis also share a common pathway. And what we are finding is that endorphins are so important that they're everywhere. I mean, we can talk about endorphins in being in the brain and functioning as a toll-like receptor 4 inhibitor as well. But with cannabinoids, the basically endorphin pathway and cannabinoid pathway are shared pathways. So, and just like acupuncture and LDN enhance each other's effect, I think there is a professor in Netherlands who wrote about that. And the studies, early studies of acupuncture, I think give great rendering of the support. But in addition, we also know that the opioid and cannabinoid pathways are interlinked. And I think that there's a chance to basically improve the outcome of that. Now, for seizures, I can say hands down, I've seen so many patients when I was one of the few first legal medical marijuana program. I was writing prescriptions for not the THC, but CBD oil. And for seizures, it works so well. Now, for other things, I think that the use is just coming out, but LDN makes absolute sense to me. And especially if they're dealing with like a Rick Simpson oil, which is a combination of CBD oil, THC oil, and the application is for cancer, I think that without doubt you have to use LDN with it. And even patients with vitamin C, I tell them LDN, you should consider LDN. I think that the data for that is coming out of Dr. Bergson in New Mexico, and I hope for a time that I can utilize the great facility of University of Kansas and do perform that kind of research. Show that how does LDN used with chemotherapy? How is it LDN if we mix it with vitamin C? How is LDN by itself? Alpha lipoic acid, of course, but how does LDN combine with ketogenic diet? And these are all things that I'm not ready or able to do research, but I am recommending my patients, and observations can be made that generally I found that LDN and acupuncture, for example, mix very well. And I've had patients who get this specialized treatment. It's not any acupuncture; it's more neuroendocrine acupuncture, and they get and they have stage 4 cancer, but they seem to live as long as they are on LDN and getting acupuncture. And I love to do trial because that's how you know it's true or not. But I think that we're the first break of LDN is accepting LDN as normalizing immune system for immune dysregulation or autoimmune diseases. But I think we're at another point that we are using LDN the next level and understanding that it's got other functions, and it's really exciting times for LDN.
Mm-hmm. You mentioned earlier about people having an ultra low dose of LDN if their endorphin levels were low. How do you know where a person's endorphin levels are?
So it's, I think you look at it functionally, and I will talk about it in next year's conference. Everyone come to next year's conference, 2019 in Portland, and you will learn more about it. But basically, what a practitioner must do is answer some questions, ask themselves questions of how do highly resilient people behave and how do non-resilient people behave? How do people, and who am I looking at? So one of my teachers, and for the listeners, it is coming for the next year's conference, and this will be also mentioned in this year's Glasgow conference in the section, so you can obtain access to that by the website. So I highly encourage you to do that. But basically, I think the physicians should not say, oh, everyone knows to start everyone on 1.5 milligrams, because no one knows. And I think that you have to determine if the patient is what my mentor would say, is the patient a grasshopper or a hippo? Not that they look like one or are light like one, but their response. Is their response to anything very, very, very super sensitive? Or is this a person who says, oh, yeah, regular dose doesn't do anything, double, triple it? And I think that gives you a clue. Now, having said that, I asked myself what would happen if I take 9 milligrams of naltrexone. So I don't recommend anyone to do it. But I did it, and immediately I had side effects. Similar side effects, patients said that they were getting on 0.1 milligrams of naltrexone. So now my practice is I prescribe 0.1 or 100 micrograms, but I tell them to cut it in half and cut it in half again. And there are one pharmacy I know that they are able to prescribe you the pill version that you can cut. This capsule version, you can't do that. So, and it's I think the more I learn about LDN, the more the biochemist and the chemist in me and pharmacologist in me that I thought that would be useless in my journey, actually turning out to be quite useful, because understanding the receptors, understanding the biochemistry, the Ki, Ka, all these things that I used to do day in, day out, thinking that, oh Lord, why are you punishing me with these science experiments? But actually now I see the reason is that I'm able to utilize this for LDN very effectively and come up with ideas to help patients.
Things have come on quite a bit. You said that the starting dose at 1.5 was the norm at the time, but many doctors actually start at 0.5 these days if the patient...
And that's what I did. That's what I did about 10 years ago, and now I moved to 0.1 because I've met patients who are my teachers, and even that, I've gone to 25 micrograms. I have a feeling that other people will catch on, and they'll give people 0.1, and the pharmacies will start compounding 0.1 or 0.25 and 0.025 or 25 micrograms. And I think that really the microdose of naltrexone is, and we're not talking about homeopathy, we're talking about receptor mediated response. And I think that the microdosing of naltrexone shows that it can rejuvenate the receptor to function, because I think if you overstimulate a receptor, basically what happens is that when receptor binds to the medication or ligand in pharmacological terms, it changes configuration. But if it's always being forced to change, it's like you're like having your paper, and if you fold it and sit on it, guess what? It becomes almost permanent. And I think what the microdose naltrexone is doing is that it's able to refresh some of the opioid receptors to go back to the resting configuration. So if you will, getting an iron and putting the iron on the folded paper, and if you do it with good technique, you can smooth it out again. So I think that right now we are only interested in what we call agonists or activator or blocker or antagonist. But I think there's a middle ground that we know about, which is antagonist-agonist action, which we have to start acknowledging. we have to start acknowledging that there's a middle ground, and that middle ground is more interesting. It's, between the land, if you're middle of farmland or middle of ocean, not so interesting. But the beach is where people like to go, right? Mm-hmm. People don't go middle of ocean and say, oh, I feel happy. Or you go to middle of farmland and say, I'm super happy. You're happy where water meets the land, and that's beach. And I think that this mixed reactions or mixing of different techniques like the endocrine, neuroanatomical acupuncture, and low-dose naltrexone or microdose naltrexone. And that's actually the work I've been pioneering for the last 10 years. I just haven't had a chance to tell people about it, is that naltrexone is great, but it's even greater when you mix with another great technique. And I think that we're going to see that, and that's going to be another blossoming of LDN.
Mm-hmm. So when you do the ultra low dosing, do you increase the dose over time, or do
Absolutely.
Yeah,
absolutely, and that's where the microdosing of naltrexone and the neuroendocrine and neuroanatomic acupuncture are very, very helpful, because without it, I think that the speed of increasing would be less. But if you are able to reprogram the brain, and that's what the neuroanatomic and neuroendocrine acupuncture can do, is really it's all about hacking into the nervous system and creating a dissonance, or forcing the brain to say, hey, there's something not right, let's do a reset. Mm-hmm. So, and then LDN also helps with that, because of the toll-like receptor 4 antagonist feature, means that it's going to prevent activation of glial cells, which is going to say, hey, brain, you should be on fire. And guess what? It does go on fire. And so that what do we hear about fibromyalgia patients? Do they just hurt? No. They have brain fog, they have cognitive impairment, they have insomnia. All that has possibility of being treated by naltrexone. But I think that some of the people will find out that some of the people who have severe fibromyalgia, severe chronic fatigue, will not tolerate even 0.1, and they'll say, I can't stand it. But if you give them 1 microgram, it gives you a chance to titrate up, because titrate up is a lot easier than titrate down. When you created this fear of medication of naltrexone, as I have done by taking 9 milligrams all of a sudden, it kind of re-educates people to be fearful of naltrexone. And that's what I'm trying to avoid in my practice, mm-hmm. so that everyone can enjoy the good effects of naltrexone or LDN microdose naltrexone.
So when you titrate it up, are you? And you said you could do it quicker with the acupuncture. Roughly, are you doubling it each time because it's so low? How do you go about titrating? Double it. Okay.
So the protocol is important. So what I do is 2 times a week they're getting treated, and if their pain is increasing, then I will double it. And the geometric progression goes very quickly. So 1 microgram, people laugh at, well, nothing. Well, before you know it, it's 2, 4, 8, 16, 32, 64, 128. And 128, guess what? You are at 0.128, and then 256. Well, we're at 0.256, and pretty soon we're in the ranges of LDN. And I think that so it goes pretty quickly. And folks, right now I have a patient that has an autoimmune condition, and I am instructing the patient to double it almost every 3rd day. Mm-hmm. Unless you have a side effect, then you back off, because I would like that person to get to about 3 milligrams, but her endorphin reserve I judged to be very low, so I didn't want her to overdo it and get in trouble. So far, no problem. So we'll see how it goes.
Mm-hmm. Well, that's really interesting. And as you say, I think more and more doctors are looking at using LDN in a low dose, and particularly for pain. And people, in my opinion, with fibromyalgia and chronic fatigue, are all ultra sensitive to all drugs. And at the end of the day, however wonderful LDN is, it is still a drug, isn't it?
It is. It is. And that's why I think the microdose is helpful, because, and I think that within probably 5 years, we're going to have laboratories that will specialize in nanogram doses and picogram doses, because there are people who don't tolerate microgram. And I've had at least 2 patients like that. Mm-hmm. But as you probably know, I had a practice that I was pushing the limit of LDN, and I feel like I'm still doing that. And by doing that, I'm learning so much about the biochemistry, pharmacology of the naltrexone, and writing the book, and that really helped me to understand the science. But writing the articles is even honing that even more, because one of them is on using LDN for pain approach, and that's very interesting because it seems like LDN is behaving as a novel anti-inflammatory molecule that targeting the glial cells, and we don't have an agent like that yet. And it's just a fascinating agent, because how I got to LDN was treating acupuncture-resistant patients, because I needed another tool. So now to marry the two is really interesting. But more on the pain relief of LDN is not just fibromyalgia, chronic pain, but you can get amazing results with neuropathy. Neuropathy, there's no great answers for, but you can use LDN to try some of my post-hepatic neuralgia patients who have absolutely intolerable amount of pain. And one patient was a pilot, and he said he has to retire soon because he can't stand it. Even clothing is torturing him. And he went on LDN. He said, it's not all gone, but 75% of the pain is gone. Now I'm not forced into retirement. I can retire when I want to.
That's amazing. I actually had the privilege of meeting a doctor whose wife and daughter both had MS, and they were taking LDN for their MS, and they had amazing results. Now, he had diabetes, and he had neuropathic pain in his feet. And the pain was so bad, and like you were saying about the pilot, he thought he was going to have to retire. And he started LDN, and the pain, he could feel it, but it wasn't a bother. You know, he could still function, and he didn't think every time he moved that he'd got all this pain in his feet. So he was really impressed with LDN, because he didn't realise it was going to work on the neuropathic pain.
It absolutely does. It's the same mechanism, because the pain is coming from the nerve, and a lot of the agents that we have is just not up to it. And I think that LDN can be a model. And what I predict is that there will be other molecules that will be utilized as toll-like receptor for antagonists. And the thing I think about LDN is that because it is related to the opioid pathway, it is so intrinsic to the body. Because it's so intrinsic to the body, I think that the body is more forgiving of LDN or naltrexone, not because of naltrexone is like special by itself. I think it's the pathway, the blessing of the pathway. That pathway of, and the other part is that naltrexone is a very unique molecule, and it is what we call quaternary amine, which means that it can penetrate fatty layer with not great amount of difficulty, and then it's there for about 4 hours, and then it gets out to the body and stays in 16 hours after being processed. And that means that you get the central nervous system, peripheral nervous system, and peripheral effect. So I had a patient that I suspected the patient somehow was making too much endorphin. And basically, and this is possible, and we know that people can convert food into morphine in the body, and I suspected this person was doing that. So, and the person was sleeping about 18 hours a day and very tired, very groggy, same as if someone would be taking narcotics. So I gave this patient naltrexone, LDN, and something amazing happened. So she says, I'm awake more. I'm awake 6 hours now, which is wonderful. But the great thing is that my constipation is much better, because naltrexone metabolite, one of the metabolites, is functional, and it's been investigated to treat side effects of opioid medication, which is constipation. Now, interestingly enough, when you put a methyl group on the naltrexone, the methyl group makes it more water soluble. And so guess what? For thousands of dollars a month, you or the physician or surgeon can prescribe methyl naltrexone, but you can get not the same, but most of the effect by taking LDN.
You are so interesting. I could sit and listen to you all day, but we have come to the end of our show. But how about if later on in the year we invite you back and find out what you've been up to?
That sounds wonderful.
And thank you so much for being my guest today.
And thank you, Linda, for having me as your guest.
This show is sponsored by integrative medicine experts at the University of Kansas Health System. Give patients time, attention, and a personalised wellness plan. They offer consultations, nutrition, counselling, infusions, neuroanatomical acupuncture, and neurofeedback, all to address the causes of medical conditions, healing the whole person, body, mind, and spirit. Learn more at kansashealthsystem.com/integrative. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.